Now, introduction. Gastric cancer is amongst the 5th most common malignancies and the 2nd leading cause of cancer-related deaths in the world. Lymph node metastasis is the most important prognostic factor in gastric cancer. Gastrectomy with D2 lymph node dissection remains the primary treatment for patients with resectable gastric cancer in East Asia. The extent of lymphadenectomy is controversial between East and West Asia and also among the Western countries. Now, this is the Japanese classification of the lymph node stations in gastric carcinoma. As we are all aware of these stations, I will just briefly go through them. Lymph node station 1 is the right pericardial, 2 is left, 3A is along the lesser curvature lymph nodes along the branches of left gastric artery, 3B is along the second branch and the distal part of right gastric artery, 4SA is along the short gastric artery, SB is along the left gastroepiploid, 4D is along the right gastroepiploid. 5 is suprapyloric, 6 is infrapyloric, 7th is left gastric, 8A is along the common hepatic artery anteriorly, 8P is along posteriorly along the common hepatic artery, 9 is celiac artery, 10th is splenic hilar lymph nodes, 11P is proximal part of splenic artery, 11th D is distal part. 12A is the hepatoduodenal ligaments along the hepatic artery proper, 12B is along the CBD, 12P is along the portal vein. 13 is along the posterior part of the pancreatic head, 14B is superior mesenteric vein, 15th is along the middle colic vessels, and the rest are along the aortic, and 110, 11, and 112 are the paraesophageal group of lymph nodes. Now, the extent of lymph node dissection, according to the Japanese Gastric Cancer Guidelines 2018, the number of metastatic lymph nodes among the regional lymph nodes, that is number 1 to 12 and 14B, N1 is 1 to 2, N2 is 3 to 6, 3A is 7 to 15, N3B is more than equal to 16 lymph nodes. The current guidelines defines the extent of lymph node dissection, that is the D level criteria, according to the type of gastrectomy, regardless the tumor location. In total gastrectomy, D0 is anything which is less than D1. D1 dissection means lymph nodes from station 1 to 7 are removed. In D1 plus, we have D1 plus the lymph node station 8A, 9, 11P. In D2, it is D1 plus lymph node station 8A, 9, 11P, 11D, 12A. For tumors which are invading the esophagus, along in D1, we have D1 plus the lymph node station 110, and D2 plus is D2 plus lymph node station 19, 20, 110, and 111. In distal gastrectomy, D0 is anything less than D1. D1 means number lymph node station 1, 3, 4, and 3, 4D, 5, 6, and 7. D1 plus is D1 plus number 8A and 9. D2 is D1 plus station 8A, 9, 11P, and 12A. In pylorus preserving gastrectomy, D1 involves the removal of the lymph node stations 1, 3, 4SB, 4D, 6, 7, and D1 plus is D1 plus number 8A and 9. In proximal gastrectomy, D1 includes lymph node station 1, 2, 3A, 4SA, 4SB, and 7, and D1 plus is D1 plus lymph node station 8A, 9, 11P. Now, indications for lymph node dissection. T1 lymphadenectomy is indicated in clinical T1A lesions that do not meet the criteria for endoscopic mucosal resection and endoscopic submucosal dissection. Clinical T1B and 0 lesions which are differentiated and are less than 1.5 centimeters in diameter. T1 plus lymphadenectomy is indicated in clinically T1 and 0 lesions which are other than above. T2 lymphadenectomy, according to the Japanese Gastric Cancer Guideline, is indicated for potentially curable clinical T2 to T4 and T1N node positive disease. This is the basic outline of the management of gastric carcinoma. Gastrectomy with D1 or D1 plus is indicated for T1B submucosal, and gastrectomy D2 is indicated for T1N positive and C2 T4 bulky nodal disease. The NCCN guidelines also is along the Japanese cancer guidelines. Now, D2 plus lymphadenectomy, which is non-standard gastrectomy. D2 plus splenic hilar lymph node station number 10 with or without splenectomy is done when the carcinoma is there of the greater curvature of stomach. D2 plus number 14B is done in distal gastric cancer with metastasis in the level 6 lymph node. D2 plus number 13, that is posterior pancreatic head lymph node, are removed when the tumor is involving the distal gastric cancer invading the duodenum. Now, metastasis to lymph node number 13 is considered M1. D2 plus lymph node 16, that is abdominal aortic lymph nodes, are removed after neoadjuvant chemo in cancers with extensive lymph node involvement. Now, what is the evidence for the extent of lymphadenectomy? We will discuss in 5 parts. Evidence for D1 versus D2, evidence for D2 versus D3, morbidity and mortality, their recurrence rates and survival benefits. The first trial that we'll discuss is the MRC randomized surgical trial, which was done in 1999 in United Kingdom by Kusheri et al. It is the first prospective study to compare D1 versus D2 gastric dissections. First, a staging laparotomy was done, which was followed by a central randomization. The primary endpoint was the long-term survival of patients with a follow-up until death or 3 years in 96% of the patients and a median follow-up of 6.5 years. The total number of the patients which were registered were 737. At the end, after exclusion, 200 patients were taken in D1 and 200 patients were taken in D2. Now, considering all of this, we see that the spleen was removed in 39% in D1 surgeries and in 9% in D2. And both of them were removed in 56% of D2s and 4% of D1. The result was that the 5-year survival rates were 35% for D1 resections and 33% for D2. There was no difference in the overall 5-year survival and recurrence-free survival between the two arms. In multivariate analysis, clinical stage 2, 3, old age, male sex, and removal of spleen and pancreas were independently associated with poor survival. These findings indicate that the classic Japanese D2 resection offers no survival advantage over D1 surgery. However, the possibility that D2 resection without pancreaticosplenectomy may be better than standard D1 resection cannot be dismissed by the results of this trial. Next trial is the Dutch randomized trial. This trial was first published in 1995 and the 11-year study were published in 2004. The aim was to compare the results of limited D1 and extended D2 lymph node dissection in terms of morbidity, mortality, long-term survival, and cumulative risk of relapse. The method was that the randomization was done before surgery. The surgeons were trained by a Japanese surgeon during the first 6 months of their training. It was done between August 1989 and July 1993. Now, this training which was done by the Japanese surgeon is important because most of the other initial trials were not being trained by a Japanese surgeon. Now, the study was followed up till 2003. The features were that in D1, the in-hospital mortality was 4%, in D2, it was 10%. The survival rate at 11 years was 30% in D1 and 35% in D2, and the risk of relapse was 70% in D2 and 65% in D1. There was no difference in survival after 11 years. This is the subgroup analysis that there was no difference in survival after 11 years, whether less than 15 lymph nodes were dissected or more than 25 lymph nodes were harvested. The survival rate was, however, 11% if lymph node at station number 10 was positive, and if the lymph node station 11 was positive, it was 8%. Whereas if there were no mets in lymph node number 10 and 11, the survival rate was 35%. Age more than 70 years had an in-hospital mortality of 5.9%, whereas in Japanese trial, it was 0.8%. The loco-regional recurrence rate in D1 was 58%, in D2 it was 45%. The conclusion was that there is no long-term overall survival benefit from extended lymph node dissection in Western population. N2 disease, in N2 disease, extended lymph node dissection offers cure, but it is difficult to identify N2 patients pre-operatively. Morbidity and mortality are influenced by age, by the extent of lymph node dissection, and pancreaticosplenectomy. Extended lymph node dissection may be beneficial, but only if morbidity can be reduced. Then we have the 15 years result follow-up. The interpretation after 15 years of the same trial was that after a median follow-up of 15 years, D2 lymphadenectomy is associated with lower loco-regional recurrence and gastric cancer-related death rates than D1 surgery. D2 procedure was also associated with significantly higher post-operative mortality, morbidity, and reoperation rates. Because a safer spleen-preserving D2 technique is currently available in high-volume centers, D2 dissection is recommended as the surgical approach for patients with resectable gastric cancer. Then the next important trial is the Italian gastric cancer study group that was conducted in 2013. The patients were recruited from 1998 till December 2006. They were randomly assigned to either D1 or D2, and intraoperative randomization was implemented centrally by telephone. The primary outcome was overall survival, and secondary endpoints were disease-specific survival, morbidity, and post-op mortality. The result is that there were 267 eligible patients which were allocated to either D1 or D2. D1 had 133 and D2 had 134. The morbidity was 12 versus 17.9 and operative mortality was 3 versus 2. Median follow-up was 8.8% for the surviving patients and 2.4 years for those who died. And it was not different in the two treatment arms. There was no difference in the overall 5-year survival rate, 66.5 for D1 and 64.2% for D2. The conclusion of the Italian trial was that there is no difference in the overall 5-year survival between D1 and D2, and subgroup analysis suggested that D2 lymphadenectomy may be a better choice in patients with advanced disease and lymph node metastasis. Recently, they have given a 15-year follow-up in 2021. The interpretation was that now, after all of this, 100 patients are alive without any recurrence. The disease-specific survival is higher after D2 in pathological T-stage more than 1 and more positive disease. Overall survival, disease-specific survival is better in D1 when the age is more than 70 years of age, 70 years. And the DSS is higher after D1 when you do it in early stages. Now, despite no relevant difference, disease-specific survival, cancer-related mortality is improved with D2 lymph node dissection in advanced gastric carcinomas. After 15 years, the overall survival in D1 was 51.3%, in D2 is 46.8%, and disease-specific survival in D1 is 65, and in D2 it is 67. Now, what are the limitations of the UK trial and the Dutch trial is that there is relative lack of experience among participating institutions and surgeons. There was routine performance of pancreaticosplenectomy for patients with proximal tumors. Older aged patients with more comorbidities were taken than the traditional Eastern patients. There was a higher non-compliance rate, that is failure to remove the requisite number of lymph nodes, of 51% in the D2 arm, and there was a higher contamination rate as well. Now, there was the Taiwan trial that was done in 2006. It was a single institutional prospective randomized trial to compare the D1 with D3 dissection in terms of overall survival and disease-free survival in advanced gastric cancer. The methods were that the patient were recruited from 1993 to 99. Staging lectrotomy followed by randomization was done in permuted blocks of 4, 6, or 8 by computer algorithm. The primary endpoint was 5-year overall survival and 5-year disease-free survival and disease-specific survival. Now, in this, 335 patients were registered, and at the end, 81 patients in the first arm were followed up for 7 years, and in the second arm, 83 patients were followed up for 7 years or more. Now, we see in the D1 surgery, distal pancreatectomy has been conducted in only 1, and in D3, that is the older version of D2, 13 had distal pancreaticosplenectomy. Now, at the end of 7 years, the patients who are alive without recurrence is 53% in the D3 arm, and the patients who have died without recurrence are only 7. The result was that the 5-year overall survival in the D3 arm was 59.5, in the D1 arm was 53.6, and the 5-year disease-specific survival was 63.1 in D3 arm and 57.8 in D1. The recurrence rate was 42 in D3 and 52% in D1. The multivariate analysis showed that nodal disease, tumor in the whole stomach, Borman type 3 and 4, allocation to D1 surgery were associated with poor survival. D3 surgery leads to stage migration, that is 9 out of 108 had a change in their nodal status after surgery. Conclusion of the Taiwan trial was that D3 LND has significant long-term survival benefit over D1. It definitely has benefit, but with acceptable morbidity. And D3 should be done by experienced surgeon. Now, when we compare the morbidity, 70% morbidity was there in Taiwan. Hong Kong trial had 47%, the Dutch trial had 43%, and the UK trial had 47%. The next important trial is the nationwide study of the impact of D2 lymphadenectomy on survival after gastric cancer surgery, which was published in February 2020. The aim was that it is a prospective study to investigate any advantage in long-term survival following D2 lymph node dissection in a Western-based population. The rationale of this trial was that the earlier 3 European RCTs conducted, none of them showed a survival advantage at 5 years. Only the Dutch trial showed benefit at 15 years. Despite these results, D1 and D2 was still widely used in the West. The methods were that all the patients in Sweden from 2006 till 17 undergoing gastric dissection with curative intent. These included adenocarcinoma of the stomach, the esophagogastric junction, CVAD3. The patients were categorized into D0, D1 or D1 plus and D2. This is the flow chart. The total number of the patients recruited at the start were 6761, and at the end only 1677 patients were undertaken after excluding. If we see the baseline characteristic, most of the patients were in their stage 1 and stage 2. And it also comprised of the tumors which were involving the lower part of the stomach. Now, if we see the end results, the overall survival was 41.5 months in D1, D2 arm and 38.5 months in D0, D1 arm. The 5-year survival rate was 43.7% versus 38.5%. So the conclusion of the trial was that this national registry study showed that long-term survival after gastric cancer surgery was improved after D1, D2 gastrectomy as compared with D0, D1 dissection. Now the prognostic impact, what is the prognostic impact of D2 plus lymphadenectomy and optimal extent of lymphadenectomy in advanced gastric antral carcinoma? This is a propensity score matching analysis, which was published in February 2020, conducted in China. The aim was to assess whether D2 plus lymphadenectomy, that is D2 with removal of lymph node station 8P, 12BP, number 13 and 14B, and para-aortic lymph nodes in subtotal gastrectomy for advanced gastric antral carcinoma. It was a retrospective study. The rationale of this study was that the JCOG trial 9501 had shown that there was no benefit in gastric carcinoma patients after D2 plus para-aortic lymph node dissection. The clinical trials which were conducted in Poland and East Asia also showed that there was no benefit of D2 plus lymph node dissection. Now, according to the latest Japanese guidelines, the lymph node station 14B is included in D2 lymph node dissection for antral gastric carcinomas. The method was that a total of 203 patients with advanced gastric cancer located in the antrum who underwent R0 gastrectomy with D2 or D2 plus lymphadenectomy were recruited between January 2003 and December 2011. The propensity score matching was used to reduce the strength of confounding factors to accurately evaluate the prognosis. Therapeutic value index was also calculated to evaluate the survival benefit of dissecting each lymph node station. We will discuss about the therapeutic value index more in details later. The result of this trial was that out of the 102 patients with D2 plus lymphadenectomy, 21 patients, that is 20.59%, were pathologically identified as having lymph node metastasis beyond the extent of D2 lymphadenectomy. But the overall survival was significantly better in D2 plus than in the D2 group. In multivariate survival analysis, D2 plus lymphadenectomy was confirmed to significantly improve the survival rate. The therapeutic value index of the patient with metastasis to lymph node station was 7.1 for number 8P, 5.7 for 12P, 5.1 for 13, 7.1 for both the para-aortic lymph nodes respectively. The conclusion was that D2 plus lymphadenectomy may improve the prognosis of some patients with advanced gastric cancer located in the antrum. The comparison between D1, D2, and D3, this was done by H. Mogal et al., published in 2019. The aim of this study was that it is a review study of all the available literature, comparing D1 versus D2 versus D3, and included randomized controlled trials, prospective and retrospective comparative and non-comparative studies. The result of this meta-analysis was that earlier studies had demonstrated increased morbidity with D2 compared with D1 with no significant survival benefit, but more recent studies have demonstrated that there is a survival benefit of a pancreas and spleen sparing D2 lymphadenectomy in patients with advanced node-positive tumors. Para-aortic/D3 dissections contribute to increased morbidity with no survival benefit. Conclusion was that in patients with resectable gastric adenocarcinoma, a D2 lymph node dissection preserving the pancreas and spleen should be considered standard for optimal staging and treatment, provided it is performed by surgeons with sufficient expertise. Extended lymph node dissections beyond D2 should not be routinely performed, as it has been shown to have increased morbidity with no improvement in outcomes. Now, this is a systematic review and meta-analysis, which was done in 2015. Systematically review and meta-analyze the evidence on the impact of three main types of progressively more extended lymph node dissection, that is D1, D2, and D3, on the clinical outcomes of the patients with primary resectable carcinoma of the stomach. The primary objective is to assess the impact of lymphadenectomy on the extent of survival, that is overall survival, TSS, and DFS. Secondary objective is to assess the impact of lymphadenectomy on post-operative mortality. The main results were that there were 8 RCTs which were undertaken. 3 RCTs compared D3 with D2 lymphadenectomy. The data for DFS were available only from one trial, and no trial was there which could give DSS data. 5 RCTs, that is 3 European and 2 Asian, compared D2 to D1 lymphadenectomy with an overall survival of 5. And DFS findings suggested that there was no significant difference between these two types of lymph node dissection. In contrast, the D2 lymphadenectomy was associated with a significantly better DSS as compared to D1 lymphadenectomy, although D2 lymphadenectomy was associated with a higher postoperative mortality rate. This is the summary of the randomized trials which are comparing D1 versus D2 versus D3. How do we come out of the dilemma of splenectomy or pancreatectomy? Now, partial pancreatectomy and splenectomy was performed as a part of D2 lymph node dissection to remove the lymph nodes along the splenic artery, that is station 11, and lymph nodes within the splenic hilum, station 10, primarily for patients with tumors located in the proximal and mid stomach. The rationale was that 10 to 20% of proximal gastric cancer will metastasize to lymph nodes at splenic hilum. The first study that was conducted in this space was JCOG 9501 trial. It is a multi-institutional randomized controlled trial to clarify the role of splenectomy in total gastrectomy for proximal gastric cancer. Proximal gastric adenocarcinoma of stage T2 to T4, N0 to N2, M0, not invading the greater curvature, was eligible. During the operation, the surgeons confirmed that R0 resection was possible with negative lavage cytology, and patients were randomly assigned to either splenectomy or spleen preservation. The primary endpoint was overall survival. Secondary endpoints was relapse-free survival, operative morbidity, operating time, and blood loss. So 505 patients were randomized at the start of the study, and 254 were included in splenectomy group, and 251 were included in spleen preservation group. Now, when we see the clinicopathological features, we see that the T2 tumors are both more in the splenectomy as well as in the spleen preservation group. There was more blood loss in the splenectomy group, and the time which was taken for surgery was also more. If we see the graphs, there was no difference between spleen preservation or splenectomy. The result was that in June 2002 and 2009, total of 505 patients were enrolled. 254 underwent splenectomy and 251 spleen preservation. Splenectomy was associated with higher morbidity and larger blood loss, but the operation time was similar. The 5-year survivals were 75.1 for splenectomy and 76.4 for spleen preservating group. The hazard ratio was 0.88. Thus, the non-inferiority of spleen preservation was confirmed. The conclusion of this trial is that in total gastrectomy for proximal gastric cancer that does not invade the gastric curvature, splenectomy should be avoided as it increases the operative morbidity without improving the survival. Now, D2 lymphadenectomy and gastric resection in a consecutive series of patients with gastric cancer. This is recently published in 2018. Now, among a clinical series composed of 1020 patients with histology proven gastric cancer, partial, that is subtotal or total gastrectomy, associated to D2 extended lymphadenectomies were performed. Splenic and distal pancreatic resection were routinely avoided unless the tumor was not closely adjacent to or directly invading these organs. Morbidity and operative mortality were recorded. The conclusion of this trial was that D2 gastrectomy with spleen and pancreas with routine preservation can be considered a safe treatment. A subgroup analysis of this trial was that the overall survival and the disease-free survival correlated with the number of ablated lymph nodes into 3 groups. In group 1, the patients who had undergone a lymphadenectomy involving 15 nodes or below, the survival rate was 65% and a disease-free survival of 60%. However, in group 2 and group 3, the 5-year overall survival and the disease-free survival was similar. That is, whether the patients have undergone a lymph node removal of 16 to 25 or more than 25. They had a similar 5-year overall survival and disease-free survival. Now, what is the role of para-aortic lymphadenectomy in surgery for gastric cancer? The rationale was that involvement of para-aortic lymph node has been detected at pathological examination in 10 to 25% of locally advanced gastric cancer, and the 5-year survival rate after para-aortic lymph node dissection is 20%. Now, D2 lymphadenectomy alone with para-aortic nodal dissection for gastric cancer, the study was published by Sasako et al. In 2008. The aim was that it is a prospective randomized controlled trial to compare D2 lymphadenectomy alone with D2 lymphadenectomy plus para-aortic lymph node dissection in curable gastric cancer patients undergoing gastrectomy. The patients incorporated had age less than 75 years, stage 2B, T3, T4, with absence of gross metastasis to para-aortic lymph nodes and negative peritoneal lavage. The primary endpoint was overall survival. The secondary endpoints were recurrence-free survival, surgery-related complications, hospital death. The study period is from July 1995 to 2001. Now, the features of comparison are that in D2 alone, the total gastrectomies were 102. In D2 plus para-aortic lymph node dissection, 97. Splenectomies were almost equal in both the groups. However, distal pancreatectomy was more in the para-aortic lymph node group. The operating time was also more. The blood loss was also more. Overall complications in the D2 plus PAN was 28.1%. The deaths were almost similar. The recurrence is almost similar. However, the 5-year overall survival was 69.2% in D2 alone and 70.3% in D2 plus PAN. The 5-year recurrence-free survival was 61.7%. Now, conclusion of this trial was that D2 plus para-aortic lymph node dissection does not improve the survival rate in curable gastric cancer. Now, what are the prognostic factors for para-aortic lymph node dissection? This study was conducted by Shunji Endo et al. In 2020. This study is to know the effect of neoadjuvant chemotherapy in patients who have para-aortic lymph nodes. Now, 20 patients who had undergone gastrectomy and para-aortic lymph node dissection after chemotherapy were enrolled from 2 institutions. The prognostic factors for overall survival were retrospectively analyzed. The result of this trial was that the univariate analysis revealed that post-chemotherapy lymph node status, metastasis, that is para-aortic lymph node involvement, histologic response to chemotherapy, and adjuvant chemotherapy were significant prognostic factors, whereas multivariate analysis revealed that the pathological end stage after chemo and absence of adjuvant chemo were independent prognostic factors. Conclusion of this trial is that post-treatment nodal status may be the best surrogate marker for gastric cancer with gastrectomy and para-aortic lymph node dissection after neoadjuvant chemo, and adjuvant chemotherapy seems to be essential to improve the survival. Now, para-aortic lymphadenectomy in surgery. What are the current indications? This was a study which was conducted by Valentina et al. In 2018. It basically is a meta-analysis. It is a review of literature that was performed and the papers reporting either the rate of para-aortic lymph node mets or the long-term survival outcomes after D2 plus para-aortic lymph node dissection or D3 were descriptively reported. The literature surveyed 14 studies. The conclusion of this review study was that the rate of para-aortic lymph node mets ranges between 8.5 and 28% in surgical series. Survival outcomes largely improved in series of patients which are treated with multimodal approach compared to those who had surgery alone. In patients with clinically detected para-aortic nodal metastasis, pre-operative chemotherapy followed by para-aortic lymph node dissection is indicated. More data is needed to clarify the indication of prophylactic para-aortic lymph node dissection in the era of multimodal treatment, and super extended lymphadenectomies have to be performed by experienced surgeons in dedicated centers. There is always a dilemma whether to do a 14V lymph node dissection or not. Now, according to the Japanese gastric cancer guidelines, the lymph node station 14V is done for distally located advanced gastric carcinomas which are invading the duodenum. The rationale behind this is that the lymphatics from the level 6, they go on to the level 14 and then they go into the para-aortic group of lymph nodes. Now, metastasis in lymph node level 6, if they have positivity, then the overall survival is less. Now, the tumors which are involving the lower part of the stomach, they have 17.1% chance of going into lymph node station 6 and then lymph node station 14. Now, this table mentions the different studies which have conducted a D2 lymph node dissection with 14V. In the study which was conducted by Masuda et al., the 5-year overall survival of 14V negative group of lymph nodes was 39.3, whereas in patients who had positive 14V lymph nodes, they had 11.9% of 5-year overall survival. However, the 5-year overall survival in patients who had positive 14B lymph nodes but negative para-aortic lymph nodes was 17.5%. So it showed that some patients may benefit from a D2 plus 14B dissection. Now the number 13 lymph node dissection for distal carcinoma has been given by Japanese gastric cancer guidelines to be done when the lesion is involving the duodenum. Now, number 13 lymph nodes are the group of lymph nodes which are present on the posterior surface of the pancreas. Now, normally the metastasis to lymph node number 13 is considered to be M1. However, the Japanese gastric cancer guidelines, they recommend number 13 lymph node dissection for carcinomas which are invading the duodenum. The rate of metastasis for lymph node of 13 is 2.43 to 7% for tumors which are not invading the duodenum. However, if a distal gastric cancer is invading the duodenum, the rate of metastasis is 16 to 26.7%. Now, the previous studies have used TVI, that is the therapeutic value index, to know the importance of dissecting the number 13 lymph nodes. Now, the study by, I would like to highlight the study by Tokunaga in Japan. It was a retrospective study in which 131 patients with duodenal invasion and lower 1/3 adenocarcinoma patients were taken, and 264 patients were there without a duodenal invasion. We see that the overall survival for patients which had duodenal invasion and who underwent a number 13 lymph node dissection was 50%. So this study concluded that lymph node 13 mets is not always an M1 disease, and some patients may also benefit from the dissection of the number 13 lymph nodes. Now, coming to the role of sentinel lymph node biopsy, early gastric cancer is more common nowadays and is related to a low percentage of lymph node mets. Hence, there is enormous interest to implicate the minimal invasive techniques, especially for this type of cancer. Now, in an effort to reduce the well-documented morbidity of extensive lymphadenectomy, sentinel node navigation surgery in early gastric cancer is intensively investigated recently. The rationale is that the incidence of regional lymph node mets is limited in clinical T1 or clinical T2 N0 gastric cancer, and D2 lymph node dissection is an overly invasive surgery for a pathological N0 disease. The limitations of pre-operative diagnostic imaging to detect the pathological mets in regional lymph nodes also has influenced many researchers to go for sentinel lymph node biopsy in gastric cancer. The first study in this space was the study conducted in Japan, that is sentinel node mapping for gastric cancer, a prospective multi-center trial in Japan published in 2013. The aim of this study is that it is a phase 2 prospective study of sentinel node mapping using a standardized dual tracing endoscopic injection technique. I have mentioned here the procedure for sentinel node mapping. The primary outcomes, the primary endpoints was to see the sensitivity of sentinel lymph nodes in order to detect the metastasis. And the secondary endpoints was the sentinel lymph node detection rate, the number and the distribution of the identified sentinel lymph nodes, and the rate of any adverse reaction. Now, in this study, a total number of 433 patients were undertaken, and 387 patients were finally recruited. In 387 patients, the sentinel lymph node were identified, which is 97.5% of detection. And the number of the nodes which were positive were 57, that is 14.7% in all the patients. Now, 57% of the patients with lymph node metastasis had positive sentinel lymph nodes. The accuracy of nodal evaluation for metastasis was 99%. 4 false negative sentinel lymph node biopsies were observed, and the pathologic analysis revealed that 3 of them were pathological T2, or the tumors were more than 4 centimeters. There was no serious adverse effect which was related to any dye. Another laparoscopic study for sentinel lymph node biopsy was done by Yong Joon Lee et al. In 2015. It is a Korean Surgical Society study. It is a phase 3 trial which is comparing the conventional laparoscopic gastrectomy to laparoscopic sentinel node biopsy with organ-preserving surgery in patients who had clinical 1A gastric carcinomas. The patients incorporated had to have T1 to T2 lesions with no nodal or any systemic mets. The tumor were less than 4 centimeters. It was at least 2 centimeters away from cardia or pylorus, and age is 20 to 80 years. The procedure of sentinel lymph node biopsy has been mentioned here. Now, the lymph nodes after the procedure were classified as hot nodes, green nodes, basin nodes, and hot and green nodes both, and they were examined by frozen section. After the sentinel lymph node biopsy, standard gastrectomy with D1 positive lymph nodes was done. The primary endpoint of this study was to evaluate the performance of the sentinel lymph nodes, and secondary endpoints was to calculate the detection rate of sentinel basin nodes and sentinel basin area, and the sensitivity and the false negative rate of sentinel basin draining area in identified metastatic lymph nodes. Now, the importance of this study is that the success rate of the surgeons doing this procedure was 84.6. 10 patients had lymph node involvement, whereas there were no patients with metastasis in non-sentinel node alone without metastatic sentinel node. The conclusion was that laparoscopic sentinel lymph node navigation using sentinel basin dissection is feasible and safe, and the quality control requires a minimum of 15 cases to be done by the surgeon before becoming well equipped with the technique of laparoscopic sentinel lymph node dissection. Now, there has been an interest in the use of laparoscopic ICG guided lymphadenectomy in gastric cancer. The study was published in 2022. The background is that endocyanin green guided lymphadenectomy has been proposed as a technique to improve the lymphadenectomy of patients with gastric cancer. Nevertheless, the experience with this procedure is quite less in Western countries. A retrospective analytic study was done in a tertiary hospital in Spain, comparing the patients who underwent laparoscopic gastrectomy with ICG cohort and without ICG guided lymphadenectomy. The conclusion of this trial was that ICG lymphadenectomy was useful in increasing the number of lymph nodes removed in patients who had a high risk of nodal invasion, and to reduce the surgical aggressiveness in fragile patients who had a low risk of nodal invasion, ICG can be used. Now, what are the predictors of lymph node metastasis in early gastric cancer? Now, in order to predict how many lymph nodes what will be the rate of lymph node positivity, a nomogram was given by Zheng et al. In 2016. Now, lymph node metastasis affects prognosis of patients with gastric cancer and determines the extent of lymph node dissection. The aim of this study was to identify the risk factors for lymph node metastasis and construct a nomogram for patients with early gastric cancer to guide the treatment. The patients were incorporated from 1996 to 2012 who had undergone gastrectomy with D2 lymph node dissection for early gastric cancer. Now, a nomogram was developed as a tool to identify the patients at risk for lymph node metastasis. The results was that 597 patients had recruited, and a nomogram was developed which consisted of 8 factors that can be used to predict the risk of lymph node metastasis. These factors were age, less than 50 years had more risk; macroscopic type, that is excavated and mixed type, had a more chance of gastric cancer mets in the lymph nodes; size more than 2 centimeters, histology adenocarcinoma; undifferentiated type, ulcer whether present or not, LVI present or not, and depth of invasion. The limitation of this study was that it was a small cohort and single center retrospective study that needed further external validation with different populations. Now, what is the role of lymph node to harvest ratio? It is the ratio of positive lymph nodes to the total lymph node harvest is called as lymph node ratio. It is an independent prognostic factor in gastric cancer. The study was done by Durwal R. et al. In 2019. Consecutive patients who had underwent gastrectomy for gastric cancer with at least 15 harvested nodes were evaluated for 5-year overall survival. The best threshold was determined using an area under receiver operator characteristic curve. Univariate and multivariate models were assessed to look for independent prognostic factors for overall survival. Now, N ratio is the percentage of positive nodes over the total number of lymph nodes that were harvested. The result was that 398 consecutive patients were evaluated, and a lymph node ratio of more than or equal to 11% had an accuracy of 0.76 and a sensitivity of 71.1, specificity of 81.7, and positive predictive value of 91. After multivariate analysis for overall survival, age more than 70, the need for total gastrectomy, the need for extended resection, and a lymph node ratio of more than equal to 11 were unfavorable prognostic factors. D2 lymphadenectomy, however, was a protective factor. The median overall survival according to the N ratio was 14 months if the N ratio was more than 11, versus 58 months for N ratio less than 11. The conclusion was that N ratio more than or equal to 11 was an independent negative prognostic factor for patients who had undergone treatment for gastric cancer with curative intent. What are the intraoperative surrogate indicators for gastric cancer patients?
How can you have a lymph node ratio of 11?
Sir, 11, sir, if we see the graph here, sir, the total,
No,
yes,
you
sir.
see, denominator is always bigger than the number involved. No, it's a
Yes,
ratio of number involved
yes, sir.
oblique number harvested.
Yes, sir.
So number harvested is always bigger than the number involved.
Yes, sir.
So ratio will always be
It
1.
will be, sir, it will be less than 1, but it is in terms of, sir, 100, sir.
Basically, when you say 11%, so it cannot be percent, no?
Sir, it is 11% in terms of 100, sir. Otherwise, sir, 0.1 we can say, sir. Now, intraoperative surrogate indicators of gastric cancer patients, long-term prognosis. Now, this is the study which shows that the number of lymph nodes examined, how is it related to the lymph node non-compliance rate? Now, the aim is to prove relationship between the number of examined lymph nodes and the rate of lymph node non-compliance and the influence on the efficacy of gastric cancer surgery. In this study, the clinico-pathological data of 1872 patients with radical gastric cancer resection with pathological T2 to T4, N0 to N3 non-metastatic patients were undertaken. What is non-compliance? Non-compliance means the surgeon has conducted one or more lymph node less than which is required for the removal of that lymph node station. The result of this trial was that among the 1872 patients, 941, that is 50% of patients had complete lymph node compliance. 1872 patients, 941 had complete lymph node compliance. 469 had minor lymph node non-compliance and 462 had major lymph node non-compliance. Logistic regression analysis showed that the clinical staging and the examined number of lymph nodes were independent risk factors for lymph node non-compliance, and multivariate analysis suggested that lymph node non-compliance was an independent prognostic factor for overall survival, whereas the number of examined lymph nodes was no longer an independent prognostic factor. So the conclusion was that when we increase the number of the lymph nodes examined, it can improve the overall survival of gastric cancer patients, which depends on the decrease of the lymph node non-compliance rate. So as surrogate indicators for long-term prognosis of gastric cancer patients, lymph node non-compliance rate was better than the examined number of the lymph nodes. Lastly, I would like to highlight the Marioma index, which is a new method which was given in 1995. It is a new method to evaluate the therapeutic value of lymph node dissection for gastric cancer, which was given by M. Sasako and Marioma in 1995. A retrospective analysis of 1281 potentially curative dissections for advanced gastric cancer using the method to circumvent the stage migration effect was given. Now in this, the frequency of, this is the therapeutic value index, which is calculated by multiplying the frequency of the lymph node metastasis with the cumulative 5-year survival rate of the patients with lymph node metastasis. Now the index of benefit, this therapeutic value index, it was beneficial because it helped to know the importance of dissecting lymph nodes in each station. And the survival benefit was evaluated without any concept of staging of lymph node metastasis. The summary of my seminar is that D2 procedure is recommended as the standard procedure by Japanese, Korean, German, British, Italian, the ISMO guidelines and the ASTRO guidelines. The NCCN also recommends a D1 plus or a modified D2 lymph node dissection. Gastrectomy with extended D2 plus lymphadenectomy may provide survival benefits for some patients with advanced gastric cancer. Neoadjuvant chemo followed by gastrectomy with extended D2 plus para-aortic lymph node dissection may be the optimal treatment for patients with para-aortic lymph node metastasis. Thank you.
Now the D2 has proved its benefit. Like, is there in this current era, like apart from T1A, where we actually do endoscopic procedures, which patients were not feasible in endoscopic, in those patients we only D1 is enough as per the Japanese guidelines and even the evidence is. Is there any other indication where we can just go get away with just D1 lymphadenectomy, even in patients with T1A and beyond. Apart from D2, just D1 in T1A and beyond tumors, just D1 is sufficient.
Sir, I have explained, sir, that the indications for D1 lymphadenectomy, sir, that the clinical T1A lesions, which are not done through endoscopic methods, so they are with node negativity.
No, apart
They
from
can
those,
be-
yes, apart from those patients. Like,
apart from-
sir, actually, I read in an article in a retrospective study, they have told in class B and class C liver cirrhosis patient, it is recommended that just the D1 lymphadenectomy is recommended. D2, they said higher mortality is there in those group of patients at risk.
Maybe Keshav, if you look at the evidence very carefully, except for the Italian trial at 15 years, showing a disease-specific survival to be higher,
Yes, sir.
showing a disease, but otherwise, no other trial has been able to show any benefit of D2 over D1 in terms of free survival or overall survival. And even for lymph node station 13, lymph node station 14, para-aortic lymph node, if you see, they are showing that if the lymph node is positive, there is a poor survival. But they are not showing any advantage of doing a lymphadenectomy. So lymphadenectomy is only staging the disease,
Yes, sir. Only prognosticate.
only prognosticate. Second thing that we have to see is all these studies are 10 to 15 years old. That was a time when the imaging was not so great. So probably with the improvement in imaging, it is quite possible that you might be able to stage the disease better with using other modalities. No, there are no studies so far. No studies so far. So it is quite possible that if you compare a, D2 lymphadenectomy with something like a PET scan, you might be able to identify retroperitoneal node, para-aortic nodes in a PET scan, or even in a very well done CT.
Yes, sir.
So you can probably stage the disease with imaging, and if station 14 is present, it is M1. Para-aortic is present, it is M1.
Yes, sir.
So probably you will be able to prognosticate them with imaging in itself, because nobody has done it so far. But the trend is towards moving towards the sentinel lymph node and the ICG guided lymphadenectomy.
Yes, sir.
So that is the trend which is now, and it is because of increased use of laparoscopic procedure for gastrectomy. Mainak, what is the optimal number that should be taken out for a gastric cancer? So what is the optimal number that you should take out? Minimum number of lymph nodes that should be in your specimen?
15 is
15 or 16, sir.
16, sir.
16. Yeah.
16.
It's in the AJCC manual.
Yes, 16 lymph nodes.
16 lymph nodes. It's in the AJCC manual.
they say 15 to 16, but preferably up to 30. They can
AJCC manual says 60. There had been trials which has compared less than 30 with more than 30.
Yes, sir.
And they have found that basically it is not the number of nodes that you take out, but it is the lymph node positivity ratio which decides the prognosis. How many of them are present? How many of them are positive? So higher is the lymph node positivity ratio, poor the survival. So this is something same as PN stage. There had been trials comparing less than 30, more than 30. I think mostly from China, and they have also shown that there is benefit is only limited to certain group of patients and not everybody benefits from it.